Welcome to Housecall. I'm your host, Dr. Steve Kariya. I'm very pleased today to welcome Howard Gleckman, a man that I have known and respected for over a decade. He will be talking to us about caring for our elderly. Please stay tuned. Welcome again to Housecall, where we will be discussing elder care. Howard, how long have we known each other?
Probably 10 or 15 years. I was on the board at Suburban Hospital. You were very much involved in medical staff leadership, and we got to know each other then, and it's been a great ongoing relationship.
It has been. I've read your book, Caring for Our Parents. Could you give us a little bit of your background and maybe tell us a little bit about your own personal experiences with your parents?
Sure, happy to. And the story is really about my parents and my wife's parents. So I was a journalist for many years, covering, among other things, healthcare. My wife was an attorney. So both of us were in the business of asking questions and learning about things and probing when we needed to. I was sitting at home one day and the phone rang, and it was my father-in-law calling to tell me that his wife, my mother-in-law, was in the hospital in Florida. We went down there to see what was going on. It turned out that she had had a massive stroke and that she had been caring for my father-in-law, who had cancer, and they never told anyone in the family. We had to make the very painful decision to end my mother-in-law's life support. And then we had to figure out what was going to happen with my father-in-law, who could not take care of himself. We brought him to Washington, got help from some people who provided very good guidance for us. And just as this was happening, I got another call, this time from my mother, telling me about my dad, who was in the hospital with what turned out to be a congestive heart failure, had an acute episode, basically had CHF. I became a distance caregiver for him. I was going down every 2 weeks to help my mother take care of him. He stayed at home for almost the rest of his life. We enrolled him in hospice. The doctors said that he probably wouldn't live more than a month or two. He ended up living 18 months. Hospice took wonderful care of him. One of the reasons he lived, I think, so long was they were able to wean him off a number of the drugs that he was on. But finally got to the point where he could not, my mom could not take care of him, and he was in a nursing home when he passed away. But I learned from that experience that long-term care, aging supports and services, is an entirely different thing than healthcare. The language is different, the goals are different, the metrics are different, everything is different. So even though I came into this with some experience with healthcare, I didn't know anything about this. And learning on the fly and making mistakes was a big part of my experience being a caregiver.
Well, Howard, not to be insulting, but I think you're downplaying. You have a lot of background and experience in economics, in studying health care for our population. So I suspect that was a macroscopic level, and now you had to do it on a very individual level.
That's right.
So that must have been kind of tough.
It was very challenging. And you're right. I mean, I look at the world generally at 30,000 feet, and now I have to look at it at absolutely ground level, and I have to deal with, the aide didn't show up this morning. What do I do? Dad fell. What do I do? Those are not 30,000 foot issues. Those are very personal, very much on the ground issues. But what I realized was, we don't have a system. We call it the healthcare system, the long-term care system. It's not really a system. It's this deeply fragmented, disorganized system without communication, getting the physicians to talk to one another, getting hospice and the physicians to talk to one another, getting the aide to work with my mother. All of that was entirely new world. And one of the things that I spend a lot of time talking to people about is how can we take this deeply fragmented system and somehow put it together so that it works for patients and their families.
How big is the problem for our nation?
The problem is enormous. You've probably heard the number that 10,000 people a day are turning 65. That's correct, but it misses the real point, which is, as you know from your practice, people at 65, pretty much their health status is no different than somebody at 55. What really matters is when you're 75, 80, 85, that's when things start to break. And the most rapidly growing population, age population in the United States are people 85 and older. The baby boomers, those people, the World War II generation, they're starting to turn 80 now. In Montgomery County, there are 200,000 people age 65 and older, and the number of people 85 and older will double in the next 15 years. So this is a big problem. It's growing. It's interesting to me that one of the reasons that we have this concern is not only because of the large number of baby boomers, but because the healthcare system is keeping people alive so much longer. Medical technology, public health have done remarkable things. The life expectancy in the United States at the turn of the 20th century was 47 years. It's now 79 years. Never in human history have we seen an increase in life expectancy like that. Life expectancy at 65 has doubled. So we're living longer, we're getting diseases of old age that we may never have gotten. So the classic example of this is dementia. You look at incidence of Alzheimer's disease. It's relatively low until people reach 80, and then it increases rapidly. So this was not a problem 50 years ago because people didn't live to 80. Now they are.
Actually, I'm told that when Johnson developed the idea of Medicare, he picked the age of 65 because nobody was living past that.
That's right. And the same thing happened with Social Security 40 years before that.
Yes.
And that's now entirely changed. And what do we now do with this population of older adults, many of whom are, doing okay, but a big issue here is how do we prevent these acute episodes? How do we prevent the falls and the pneumonias and the UTIs? The system's not set up to do that. The system's set up to treat people after they've had those episodes, but it's not set up to prevent them. And I think there's a lot more that we can do, the physicians can do, and frankly, families and patients can do to prevent a lot of this, which would have the benefit of, one, improving their quality of life, and two, saving the system a massive amount of money, which is also important.
What do older adults want from their healthcare professionals?
So the first thing to say, of course, is every older adult is different. So everybody wants something different, but they want to be listened to. They want to feel that they're part of their care team. They don't want doctors to tell them what to do. They want physicians to share ideas. They want to be independent. This idea of agency is very important. Somebody is starting to lose their ability to do the things they've done all their life. The last thing you want to do to them is make them think they're helpless. So allowing them to maintain some agency and some decision making of their own is really important. They want doctors to listen to them. And sometimes I know that older patients, it's time consuming, it's complicated, they have a long story they want to tell you before they get to the point, but it's important to be able to listen. It's important to recognize that they may not hear as well as they used to, and you need to take that into account. And then you need to take into account the relationship between the patient and the families. It's very important that the family caregivers are engaged, involved in this, but on the other hand, you don't want to talk past the patient, ignore them, and just talk to the family caregivers. It's a difficult balance.
So what are the systemic problems that interfere with good communication between the doctors and the patients?
So you probably know this better than I do, but time. Physicians don't have a lot of time these days to spend with their patients. You have to get to know these older patients, I think. You have to get to know every patient, but particularly I think these older patients, it's really important. Money. Physicians are very candid with me when I talk to them about it. I'll say, well, can you provide them with connections to senior services, for example? And physicians will say to me, nobody pays me to do that. No. And I think the other thing is knowledge. You have a specialty, you're really good at your medical specialty. You can't be expected to know how to connect somebody with Meals on Wheels and transportation. That's kind of not what you do. The important thing to know is there are people out there who do that. And I think where doctors can really help here is just make the connection between the patient and the patient's family and those people who have the expertise that the physician might not have.
So what's the role of the family as caregivers and as advocates for their loved ones?
So again, it's going to be different in every family. The family dynamics are amazing and challenging, and you just kind of never know where they're going to go. But certainly if you have an adult child, for example, who's engaged, who's in the picture, I think it's very important that they be allowed to participate as much as the patient wants them to. So for example, you prescribe medications. It's really important that a patient comply with those meds. They may be taking 5 or 6 or 10 other meds. They may not be able to manage that themselves. Very important that the family caregiver understand what the medications are, why they're being taken, how they interact with the other drugs, and then help make sure that the patient can comply with that. Other simple things, somebody's a fall risk. Physician may say, Mrs. Jones, have you got grab bars in the bathroom? And that probably going to be the end of the conversation. Family caregiver can say, Mom, let's bring somebody in, let's put them in. Because as a physician, you can't really follow up on that, but the family caregiver can. So I think there's a lot they can do to just sort of help make sure that this very complicated system is working the way it's supposed to work. Very difficult for the patients themselves to do it.
So does that mean they have to come to every office visit?
I don't know if they need to come to every office visit, but I think they need to come to the important ones. So if you have a patient who's relatively stable, not much change, but you just want to see him every 6 months, maybe it's not necessary. But if you notice that there's some real change, maybe it's worthwhile for the physician to get in touch with the family caregiver and say, Mom is not doing real well. I've seen A and B, and I need to see her again, and I think it'd be good for you to come in.
So how do physicians then support the family caregivers? Sometimes there are family interactions that are not always harmonious, shall we say?
That's right. It's difficult, and honestly, the family caregiver is not your patient. Your patient's your patient. This person isn't your patient. But I think it's important. You can, in a sense, read the room. You can see, for example, that let's say a spouse of a patient, you've seen the spouse and the patient now 3 or 4 times, and you notice that that spouse is not doing as well as she used to. Maybe she's not as engaged. Maybe she's not remembering some things that you talked to her about before. Maybe she's having trouble walking across the room. I think there's an opportunity for a physician to say, Mrs. Jones, you need to take care of yourself. You're not going to be able to take care of your husband if you don't take care of yourself. So it would probably be a good idea if you went to see your own physician. Do you have a physician? If you don't, is there something I can do to help you? But if you do have a physician, I'm getting a little concerned about you, and maybe it'd be good for you to go see them. I told the story of my in-laws. That was the story about my mother-in-law. She was not taking care of herself. She was so fixated on caring for her husband, and she got a stroke and died.
I apologize. So we have to do a brief break for a public health announcement. We will be right back. Please stay tuned.
Okay, Dad, look at you.
I look nice, don't I?
I see you.
Yeah.
Adding your own flavor to fashion comes with age.
Oh man, that's the best one yet.
Forgetting how to add doesn't.
Knock that out of your hand.
Finding it difficult to work with numbers may be a sign of Alzheimer's.
Dad, are you okay?
An early diagnosis can help improve the quality of life for your loved one.
All right.
High school. Yeah.
Hey, Dad. Do you want to talk about what happened earlier?
Learn the warning signs of Alzheimer's. Some things come with age. Some others don't.
Welcome back to Housecall. I am Dr. Steve Kariya, and our special guest today is Howard Gleckman, who's talking to us about caring for our parents. So, Howard, how can patients, families, and physicians approach end-of-life care?
It's a really, really important question. One of the things I've found is that a lot of physicians avoid it, and I think it's a real tragedy, and of course, families avoid it. So I think the first thing to do is communicate. If you have a patient who has a terminal illness, I think it's very, very important that there be an honest conversation about it. There's a lot of research out there, as I'm sure you know, that says that for the most part, patients want to know. This old canard that said, well, I don't want to tell them because they'll give up. That's not how patients respond, generally. They say, well, I only have so much time, I'm going to do things that I can still do with the rest of my life. Putting a name on something, because I think honestly a lot of patients who are dying know it, but they need somebody to kind of tell them what's really going on. In some ways I think it makes it less frightening. So if they haven't done an advance directive, it's critically important that they do one. If they haven't designated a family member as a healthcare proxy, healthcare power of attorney, it's very important that they do that. And that they have conversations with all of their family, not just their spouse, if their spouse is still living, but their adult children, and even their grandchildren, and talk about death. Americans struggle with this. Other cultures, not so much. My wife was a hospice chaplain, and she...
After being a lawyer.
After being a lawyer.
After being a reformed lawyer.
After being a recovering lawyer.
Recovering
lawyer, we like to call it. She was a hospice chaplain and got to know a lot of the aides, and she once met an aide from West Africa who told her that the patient that my wife and the aide were caring for was going to be her last patient in the United States, and she was going to go back home. And Anne asked her why, and she said, because you Americans don't know how to die. She was so offended by the fact that this patient had essentially been abandoned by her daughter, that she couldn't take it anymore. And this is something we just don't want to talk about, and I think it's really, really important that we do, that we confront it. One of the things greatly disappointing to me is I've discovered over the years that oncologists, who ought to be the people who could discuss this the most, are often the worst at it. And I don't know why. Some people say it's because they see the death of a patient as a personal defeat for them. I'm not going to get into psychology, but whatever it is, I wish they were better at this, at having these conversations.
So we've talked about doctors and patients, but I think there's many times when the family caregivers also need to be both drawn into the conversation as well as have their own needs met and maybe additional training for them.
Absolutely.
So can you talk to me a little bit about what your research has uncovered with this?
Sure. So we put an enormous burden on family caregivers.
We do.
There are somewhere between 20 and 80 million family caregivers in this country. One of the reasons why there's such a spread of estimates is because they often don't see themselves as family caregivers. They just see themselves as the daughter,
yeah,
or the wife. But that's what they are. We discharge people from the hospital often with significant supportive needs, not just in terms of bathing and dressing and feeding, but often in terms of managing medical equipment or doing wound care. And we do this often without training in any way the patient's family members. We'll give them a piece of paper with instructions on it, and that's the best they get. And they're terrified of making a mistake. And I've had conversations with people who have said, I was afraid to, for example, manage an oxygen tank, because if I mess it up, I could kill my husband. Well, a bit of basic training would go a long way. Providing emotional support, very important. I've learned from my own experience and from talking to many other people, family caregivers think they're alone. They think there's no one else in the world who's doing what they're doing. And just the opportunity to have them talk to other people who have the same kind of experience, very important. That emotional support as well as the personal training.
So are there community support systems that can help people with these crises?
There are many support systems. So, for example, there are disease-related groups. If you have a family member who's got Parkinson's, there are local Parkinson's groups that provide both guidance in terms of what to expect in terms of providing physical assistance, but also provide that kind of emotional support. There are organizations in this area that just generically provide support for older adults and their families. So I was the board chair of an organization called the Jewish Council for the Aging, which is in Rockville. They have a helpline, for example. They have an adult day program for people with early stage dementia. In DC, in Northwest DC, there's Iona. There's Seabury in DC. So there are these groups, local community-based organizations, and this is what they do. They provide support for older adults and their families. So it's easy, should be easy, for a physician to just hand a brochure to a patient, and the patient and family members can take it from there. But they don't even know where to start. Unfortunately, in 2026, people's first reaction is, I'll go to the internet. And unfortunately, a lot of the information on the internet is junk. It's not only not helpful, it's actually dangerous. So finding a credible source of information, and that could be the physician, but more often than not, it may be one of these nonprofit organizations. And they're out there, and if physicians can just connect their patients with these organizations, they're doing a great service.
I know many of the home care programs also partner with hospice. So I think for some of our listeners, could you educate them a little bit about the differences between hospice and palliative care medicine?
Yeah, this gets very complicated. So palliative care medicine is providing the support somebody needs, the medical care somebody needs to live the best quality of life that they can, keeping them comfortable. Hospice is sort of you think of it as a subset of palliative care. It is for people who are dying. You may require palliative care and still live many years. Having that comfort care can be very important to your quality of life, but you're not dying. Hospice is for people who are dying and their families. And it's a wonderful support. It will provide a nurse, it will provide a little bit of home care, provide a social worker, provide a chaplain if you like one, like my wife. It provides friendly visiting. So much of what family members need is a break, especially if your loved one is dying.
What they call respite care.
Respite care, correct. Just getting out of the house and knowing that you can leave the house and your loved one is being cared for. I mentioned, this is a little away from hospice, but I mentioned that Jewish Council for the Aging has adult day programs. This is for people with early stage dementia. It's another variation of the same story. Your spouse has dementia, you are terrified about leaving your spouse home alone. Adult day is someplace they can go for 4 or 5 hours a day. They'll get meals, they'll get activities, they'll get socialization, and most importantly, they're safe. And you can go to the movies, you can go visit your friends, you can go sit on a park bench, you can do all those things that we all take for granted that you can't do if you're constantly worried about something happening to your loved one.
It's a break from the 24/7 constant care.
That's right. And the burden, the emotional burden of that 24/7 care is incalculable. There's research out there that talks about how difficult it is to be with somebody even during a period when nothing's happening, because you're always worried that the shoe's going to drop and something's going to go wrong. This is, by the way, one of the reasons why paid aides home health aides often have emotional issues themselves because they're sitting there for hours and hours and hours waiting for the next crisis. And emotionally, that's very difficult on them too. So, you know, you think about the periods of time when you're sort of being an active caregiver, when you're managing medications, or you're calling the home health agency and saying the aide didn't show up, or you're helping bathe somebody. There's that. But then there's also that time where you're just sitting there worrying.
Yeah. What are the biggest trends in healthcare policy that will affect the care for our rapidly growing but aging population?
So Steve, there's good news and bad news here. I'll start with the bad news and then I'll end with the good news. So the bad news is current policy changes, for example, in Medicaid, are making it very, very difficult for people to get Medicaid help. These are people who are very poor and very sick. Because of the changes that were made in the legislation last year, Maryland is going to lose, the state of Maryland is going to lose $2.7 billion in federal assistance for Medicaid. Inevitably, that's going to mean either they're going to restrict eligibility to enroll in Medicaid, they're going to reduce the benefits that you receive in Medicaid, or they're going to pay the providers less money. And the providers already aren't getting enough money to make
No, they're not.
Medicaid care worth their while. Those are the only three options. Or the state's going to have to raise taxes by a lot to make up the difference. But $2.7 billion is a lot of money. So it's inevitable, unless the law is changed again, that there are going to be additional cuts to Medicaid in Maryland as well as the rest of the country. That's the bad news. The good news is that in Medicare, there are a number of demonstration programs that have begun over the last several years that are aimed at breaking down this barrier between healthcare and supports and services. So I'll give you a couple of examples. The Biden administration proposed, and the Trump administration is continuing, a program called GUIDE. GUIDE is a program that will pay doctors and other Medicare providers additional money, a few $100s per patient per month, to provide care navigation services and other supports to family members of people with dementia. Now, this is a sea change for Medicare, because Medicare always took the position that we have no responsibility for caregivers, and things like navigation, that's not health care. We don't do that. Mm-hmm. That's changing. So the GUIDE program began last July, so we have almost a year's worth of experience with it now. Patients really like it. Physicians are still trying to cope with it, but it's a very interesting model, and it's providing that kind of support, caregiver support, that didn't exist in Medicare. There's another example. Medicare for years and years and years has been trying to do what they call accountable care organizations. This is a way to pay physicians, instead of paying them per unit of care, paying them for what they call a sort of a bundle payment for an episode of care. So, for example, you have a patient who comes in with pneumonia. Instead of paying you for each x-ray and each office visit and each medication, instead they'll say, we're going to pay you an X amount of money to take care of your pneumonia patient. So that's been there for a long time, for about 20 years, and Medicare's really never quite gotten it right. A lot of physicians have tried the accountable care organization model and left it because there's too much paperwork and the compensation wasn't really very good. So they've just reformed it again. One of the reforms in this is they are now defining explicitly as an episode of care falls prevention.
Oh.
Again,
okay.
This is brand new. So my primary care physician can determine that I am a fall risk, and then think about what can we do to make sure that Howard doesn't fall. Well, maybe it's changing his medications. Maybe it's dealing with malnutrition and dehydration. Maybe it's getting that grab bar in the bathroom. Suddenly, we're asking physicians and paying physicians to think about those kinds of things that until now have been outside the scope of their practice. So it's, again, a very important change. It's just a demonstration. It's an optional program. We'll see if it works. We don't know. but they're thinking correctly about taking this fragmented system and trying to put it together.
Well, look, Howard, this has been fascinating and really a wonderful sort of view into, as opposed to a deep dive into all the problems that we share. I want to thank you so much for your wisdom, for your insight, and I want to thank our viewers for continuing to watch us. Until next time, this is Dr. Steve Kariya for Housecall.